Greetings, and thank you for joining us for this webinar today. It's Protecting Children from RSV, Updates on Prevention, Vaccines, and Monoclonal. My name is Chad Worley. I am the Lurie Children's Physician Liaison for the City North and for the North and Northwest suburbs. And I am joined today by our presenter, Dr. Tina Tan. She is an attending physician for Lurie Children's Division of Infectious Diseases, medical director for Lurie Children's International Adoptee Clinic. She is the president of the Lurie Children's Medical Dental Staff, president of the Infectious Disease Society of America, professor of pediatrics at Northwestern University Feinberg School of Medicine, editor-in-chief of Contemporary Pediatrics, and editor of the American Academy of Pediatric Red Book Atlas of Pediatric Infectious Diseases. Rush University Medical Center designates this live activity for a maximum of 1.0 AMA PRA Category 1 credits. So physicians, to receive credit, participants are required to participate in the live activity and complete the post-test and evaluation sent via email following this meeting. Once the surveys are completed, a certificate will be immediately available. There's no fee to participate in the activity or for the generation of the certificate. I'd like to remind you all attending that this session is being recorded. And I'd like to encourage you to please type in questions into the Q&A section, and we will try to get to as many of your questions as we can following the presentation. So we will answer all your questions afterwards. So please, I encourage you to ask them. But without further ado, Dr. Tan, welcome and thank you for doing this presentation for our community providers today.
No, thank you. This is a real honor. And I want to thank everyone out there for the incredible work that you do. But we're going into RSV season, so I think this is a good way to basically help protect more individuals.
Oh, you are so right.
Basically,
I was just going to say, many of the providers that are on with us today have been asking us for this webinar, and it just came as a great timing, and we're just super excited. So I'm going to go ahead and let you go ahead and move your slides and do your presentation. I'm going to go off camera and mute myself, but I will be monitoring the Q&A room, and we'll do that afterwards. Thank you, everybody.
Perfect. So basically, the learning objectives are to review RSV prevalence and associated lower tract infections and hospitalizations, evaluate the safety and efficacy data of the monoclonal antibody therapies to prevent RSV, and implementation strategies to improve passes immunization rates and mitigate the impact of RSV disease. So first, we're going to look at the epidemiology. And as you can see here, RSV infant hospitalization rates around the world are fairly high, and the rates here are reported as 100-person years. But you can see that China has very high rates, as does France, Spain, the UK, Japan. So this is a problem that people actually encounter worldwide. But more interestingly is the intensive care unit rates among infants and children with RSV. The thing to remember is that the majority of the ICU infant admissions are among previously healthy infants born at term, and the rates in the US are higher because in other parts of the world, they don't have the same number of ICU beds that we have in the US. But you can see that our ICU rate is around 27%. And people talk about this and ask about this all the time. And we know that RSV seasonality normally is between October and March. However, we know that during the COVID pandemic, the season actually shifted and decreased due to the restrictive measures that were being used during the pandemic. And then post-pandemic, we actually saw that the season began earlier, and there were actually multiple RSV seasons, so-called, during that 2022-2023 year. But now it looks like we are moving back to where RSV season normally is, which is October through March for most of the US. However, the thing to remember is that the seasons start at different times of the year, depending on where you live. And we know that RSV epidemics are earlier in the Southeast and later in the regions that are further north and west. And so we know that the RSV season in Florida actually starts earlier. It starts at the beginning of August and can last longer than in other regions. And this is based on information from RSV-related outpatient visits and hospitalization that in Florida are actually documented year-round. But you can see that for us in Illinois, normally RSV season will start end of September, beginning of October, and then go through March. And when you look at who's at risk for RSV, we know that RSV accounts for almost 10% of all-cause hospitalization in infants, and all infants are at risk for severe RSV disease, with up to 3% of children in their first year of life being hospitalized due to RSV. And when you think of some infant populations that are even at higher risk for severe disease, it really is your preterm infants. The degree of prematurity actually correlates with the risk of hospitalization, so that the more premature an infant is, the higher risk there is for hospitalization if they get RSV. And we know that from different studies, it shows that 8 to 12% of these premature infants that get RSV will require hospitalization if they don't get preventative measures. And then infants who have chronic lung disease because they're premature, infants that were discharged from their birth hospitalization during RSV season, and then infants with underlying conditions such as congenital heart disease, Down syndrome, neuromuscular diseases. And the thing to remember is that Native American infants and children, especially those from tribes in the Southwest US, and Alaskan Native infants and children are at higher risk to develop severe RSV disease if they get it. But we know that almost every child will get RSV by 2 years of age. And when you look at the risk factors for poor outcomes with RSV-associated lower respiratory tract infection, you can see again that it really is children that have a comorbid condition, chronic lung and heart disease, Down syndrome, prematurity, especially the more premature they are, the higher risk there is for a poor outcome. Co-infection with other viruses. Male sex actually increases your risk for poor outcome, as well as the younger you get RSV, the higher risk you are for poor outcome from the disease. So, what steps can we take to improve are processes for assessing risk of RSV infection and disease in children entering or during their first RSV season. And this basically shows you other risk factors for severe RSV disease beyond infancy. So just remember that adults 60 years of age and older, especially those living in nursing homes and long-term care facilities, are a very vulnerable population and are at very high risk for severe RSV disease. The other major risk factor that applies to all of our patients is that if you have persons living in very crowded living conditions with multi-generations living in the same household, this actually increases the risk for the development of severe RSV disease if they get the disease. And then persons of any age with a weakened immune system, especially those undergoing bone marrow transplant. And as we mentioned before, persons that have underlying chronic heart and lung disease, as well as chronic liver, kidney, hematologic disorders, diabetes, if they're severely obese, and if they have a neuromuscular disorder that leads to swallowing dysfunction. So these are other risk factors that can affect everyone in a household if they get RSV disease to develop severe disease. And RSV really is a burden across all different pediatric age groups. Globally, it's responsible for over 3.6 million hospitalizations and 100,000 deaths each year in children under 5 years of age, with 50% of the deaths occurring in infants under 6 months of age. And in older adults, 60 years of age and older, it's estimated for 2025 that RSV is going to cause over 500,000 hospitalizations and almost 40,000 deaths in high-income countries. And you can see that the annual cost of RSV hospitalization and disease is extraordinarily expensive at $6.6 billion here in the US. Now, the thing also to remember and really to try and prevent is that RSV infection during infancy can have long-term effects, especially asthma and recurrent wheezing. And we know that if infants had RSV infection during their infancy, they are at much higher risk for developing asthma and recurrent wheezing episodes if they get other types of respiratory infections. And basically, we know that 15% of the 5-year current asthma could be prevented by preventing these infants from getting RSV during their infancy. Now, the other thing to remember about RSV infection is that the vast majority of the cases are seen in the outpatient setting, accounting for 97% of outpatient visits for RSV. You can see that there are about 472,000 ED visits, anywhere from 50 to 60,000 hospitalizations, and about 300 deaths a year. And you can see that RSV is extraordinarily expensive in the under age 2 years group, at about $1.6 billion here in the US. So let's look at some of the current strategies for the prevention of RSV disease. And this basically shows you some of the non-pharmacologic strategies to risk reduction of children and infants getting RSV. And all of this also applies to all other viral respiratory infections. So we want to avoid close contact with sick individuals, wash your hands very often, practice good cough and sneezing etiquette, avoid touching your face if you didn't wash your hands and you've been around individuals that have a respiratory illness, clean and disinfect surfaces, and if you're sick, please stay home because you can spread all these infections, especially RSV, to other individuals. And if you look at protective factors that are pharmacologically based, you can have maternally derived RSV neutralizing antibodies that either are naturally occurring and they get boosted after a mom receives RSV vaccine during pregnancy, or you can give the RSV monoclonal antibody to the infant for passive immunization to protect them. And so basically, moms should be getting their vaccine between 32 and 36 weeks of gestation. And the babies should be getting it, if they're born during their first RSV season, or if they are still under 8 months of age and will be entering into their first RSV season, then they should be protected with the monoclonal antibodies to prevent them from getting RSV. So when you look at the monoclonal antibodies, normally we give it between October and March. And just remember that for nirsevimab, you can give a second dose of the monoclonal antibody to children that are 8 to 19 months of age and are at increased risk for severe RSV if they're going into their second RSV season. Maternal vaccination during pregnancy, given at 32 to 36 weeks of pregnancy, and normally that's between September and January that the moms would receive the vaccine. And then just remember that there are 3 different RSV vaccines that are available for older adults, and they can be given this vaccine any time of year. So what steps can we take to improve our processes for ensuring that maternal RSV vaccine and monoclonal antibodies are being recommended for all the appropriate patients? So this basically shows you information for the vaccine trials from pregnant women that were done and what the efficacy of the vaccine was. And you can see that the vaccine really does protect out to 180 days after birth. The top part of the graph shows you the efficacy in the moms, and the bottom part of the graph shows you the efficacy against severe RSV disease in the infants. And you can see, even by 90 days since birth, efficacy in infants, if mom received the vaccine, is still 82%. And even by 180 days, it's still almost 70%. So maternal vaccination does really significantly protect these young infants against getting severe RSV disease. And if you look at the monoclonal antibodies that we can give our patients, basically there are two of them that we're going to talk about. We're going to talk about nirsevimab and sesrovimab. And you can see that they are both monoclonal antibodies that actually target different sites on the RSV F protein inhibitor. Half-life of nirsevimab is 71 days, and of sesrovimab it's 44 days, so a little bit shorter. And route of administration for both of these is intramuscular, given once during the RSV season. And just remember with nirsevimab, you can give a second dose to infants 8 to 19 months of age that are considered at high risk for severe disease. And the dose of nirsevimab is based on weight. So if you're under 5 kilos, it's 50 milligrams. If you're over 5 kilos or more, it's 100 milligrams. And for those that are going into season 2, it's 200 milligrams for the dose. And for sesrovimab, it's the same amount for all infants, regardless of their weight. Now, this is the phase 3 MELODY study that looked at nirsevimab efficacy in late-term and term infants. And basically, what we know during that time is that compared to placebo, all infants that received nirsevimab were much better protected. And I can tell you that there is another study that is a compilation of all the studies done. It's called the BEAR study, and efficacy is much, much better. So if you look at medically attended RSV lower respiratory tract infection, the efficacy is 87.2%. If you look at hospitalization for these infections, efficacy is 98%. And if you look at very severe disease requiring ICU admission, efficacy is 90%. So definitely much, much better when you take into account all the different studies that were done. And again, this basically shows you that if you look at maternal vaccination, again, the top one really is the protection for mom. The middle column there is mom's protection from hospitalization, and the bottom column there, or the bottom row there, is looking at infants. And again, if you look at nirsevimab efficacy for lower respiratory tract infection, looking at the BEAR study, it's 87.2%, hospitalization is 98%, and severe RSV with ICU admission is 90%. So a very, very effective monoclonal antibody to protect infants. Now, the other monoclonal antibody that was just licensed this year is sesrovimab. And half-life, again, is a little bit shorter at 44 days. And generally, it was well tolerated in all phases of the clinical trials. The most common adverse events were injection site erythema and pain, and also kids got rashes, but this is also another option that is effective in protecting infants. So this basically shows you the effectiveness in the phase 3 CLEVER trial compared with placebo. And so you can see that prevention of lower respiratory tract infection was around 60.4%. Hospitalization was 84.2%. Hospitalization in the ICU setting was about 91%. And then severe infection, the bottom row there is about 92%. So you can see that sofrovimab also is a very good option to protect infants against getting serious RSV disease and requiring hospitalization. And when you look at the side effects, again, the most common ones are injection site erythema and swelling and rash. So if you look at the current guidelines and recommendations for the use of all these agents, we know that for the prevention of RSV disease in infants and children, if all infants age under 8 months born during or entering their first RSV season, so that's between October and March, are recommended to receive a dose of the monoclonal antibody. And then children between 8 and 19 months of age who are entering their second RSV season and are at increased risk for severe RSV disease are recommended to receive a dose of nirsevimab at 200 milligrams. So if you look at the kids that are considered at increased risk for severe RSV disease, we already really covered these, but those are kids with chronic lung disease or prematurity, severely immunocompromised children, those with cystic fibrosis and signs of severe lung disease. And then just remember that the American Indian or Alaskan Native children are at increased risk and should receive a second dose of nirsevimab as they enter their second RSV season if they're between 8 and 19 months of age. And if you look at the timing of when the monoclonal antibodies should be given, really we should try to give it during the birth hospitalization or within 1 week of birth in the outpatient setting. And optimal timing is right before RSV season starts, but it can occur at any time during RSV season for the age-eligible infants and children who have not yet received the dose. And infants with prolonged birth hospitalizations for multiple reasons really should be given the monoclonal antibody shortly or promptly after hospital discharge. And the major thing to remember is that these monoclonal antibodies do not interfere with the immune response to all the other routine childhood immunizations that these infants can receive. And so you can simultaneously administer the monoclonal antibodies if with age-appropriate vaccines, if that is needed at the time. So what steps can we take to improve our processes for ensuring that RSV monoclonal antibodies are administered prior to discharge from birth hospitalization or within 1 week of birth for all appropriate patients. And this basically shows you the AAP nirsevimab administration visual guide. So basically, if the patient is under 8 months of age and the mom did not receive RSV vaccine when they were pregnant, or if it's unknown, then you basically give this patient a dose of nirsevimab during the current RSV season. If the mom did receive RSV vaccine when they were pregnant, but the infant was born within 14 days of mom receiving the vaccine, then those infants should receive nirsevimab. And just remember that if a patient is 8 to 19 months old and meets the high-risk criteria, then you should also give them a dose of nirsevimab. And this basically shows you guidance on maternal vaccination and whether or not infants should receive a dose of the monoclonal antibody. So if mom did not receive the vaccine less than 14 days before birth, has an unknown vaccine status, has HIV, or has an immunocompromising condition, then they may not have reliable transfer of neutralizing antibodies to the baby, and the babies should receive a dose of nirsevimab or sefovimab. Also, all infants that are born prematurely who require bypass surgery or ECMO, have significant congenital heart disease, require supplemental oxygen, and require an intensive care stay, they should all get nirsevimab or sefovimab. Otherwise, if they don't fit those criteria and mom was vaccinated, then they don't need to get an additional dose. So if we look at RSV prevention in the US, basically, this shows you the number of individuals that need to be immunized to prevent one poor outcome. And you can see that for an outpatient visit, it's 17 for nirsevimab and 40 for a maternal vaccine. ED visit, 48 for nirsevimab, 115 if they got maternal vaccine. And if you go down the list, you can see that twice as many moms need to be vaccinated to prevent all these other things from occurring compared to if a baby gets nirsevimab. So just also remember that the BFC program really can improve RSV antibody access, but is underutilized by multiple hospitals. And across the US, we know that 50% of newborns do qualify for the BFC program, but as of mid-2024, only about 34% of birthing institutes were enrolling children in the VFC program. So if you have patients that need to go on the VFC program, please enroll them. And this basically shows you AAP guidance for implementing nirsevimab in ambulatory practices. You want to make sure that your entire team is educated and share resources and information, communicate with the parents, provide educational materials with background information, and ensure the information is available in the languages spoken by your patient population, and communicate with the birthing hospital so that they can either administer nirsevimab prior or sefrovimab prior to discharge, or if they don't, then you can administer it in your practice. Also, try and communicate with the OBGYNs and have them know that maternal RSV vaccine is very effective when it's administered in protecting infants against RSV. Create workflows in your office for the different patient scenarios, and create processes for sharing immunization information sheets and recalling and rescheduling patients who qualify for nirsevimab outside of the newborn period. And this basically shows you some talking points you can use to communicate with parents about RSV immunization for infants. Because as you all know, there is now a significant increase in the number of individuals that are vaccine hesitant. And basically, one thing to explain to parents is the difference between vaccine and passive immunization with the monoclonal antibody, and that you are actually able to give antibodies to the baby, and their immune system doesn't have to create their own antibody. Also tell parents that there's no treatment for RSV disease beyond supportive care, and nirsevimab and sefrovimab are the preferred monoclonal to use, and highlight that these monoclonal antibodies are very safe and very effective at protecting the infants. Now, this basically shows you what might contribute to vaccine hesitancy and immunization, and you can see it's multifactorial and can involve a number of different agents. It can be contextual influences, individual and group influences, which are primarily social media information, and then vaccine and vaccination issues that the parents might have. So, examples of specific parental concerns are shown here, and I don't have to go over these because I'm sure you hear one or more of these in your offices every single day. But this just shows you examples of parental concern and misconception that continue to circulate out there in the community. And what steps can we take to improve the ways in which we educate parents about RSV prevention, maternal RSV vaccine, and RSV monoclonal antibody? Well, basically, we want to take the AAP approach and optimize the presumptive approach, so that even if the parent has voiced resistance, you want to use the presumptive approach and make sure that medical assistants and other staff that communicate with the parents also use the presumptive approach. And even after parents tell you that they're hesitant, then you basically can ask parents what their concerns are and what their questions are about vaccination and immunization. And basically help the parents feel that they're supported, appreciated, and understood by listening to why they have concerns. Continue to encourage a trusted partnership between the parent and yourself, and basically explain to the parents why you feel that immunizing the children are so important. And you can even take a personalized approach and say that you immunize your children, your family members, and you want to do what's best for their children. But also be aware that there are barriers to vaccinations among healthcare providers, not so much in pediatrics, but in family practice and in other situations. And many times, these providers are not, comfortable giving vaccination and addressing vaccine hesitancy. And so you may want to try and educate these providers on why the vaccines are so important and explain to them why RSV disease is a major factor that can cause serious infection in their patients, and you need to protect them against the disease. And basically, these are just some guidance as to, how you can improve uptake of monoclonal antibody and maternal immunization. And this is basically looking at 90 days after birth and then 180 days after birth. And you can see which of these types of action plans work best in your offices. And so basically, when you're developing your action plan, you want to look at risk assessment, RSV prevention, implementation strategies, and optimization of RSV prevention. And with that, I'm going to stop here. Thank you so much for your attention. And this shows you how you can go and receive credit.
Dr. Tan, thank you so much. This was very informative, enlightening, and I hope everyone in the audience really got a lot out of this, because I certainly did. And given the amount of feedback we have in the Q&A section, it sounds like we have some engagement here. So I'm going to start with the first question, if you don't mind. And the first one says, what specifically is the reason for Alaskan or Native American children to have more serious diseases? Or is it more of availability of healthcare or other SDOH issues?
It's multifactorial. So one is that all these kids live in very crowded living conditions. And so they can get RSV from other people in the household. Also, it's access to healthcare, harder for them to do it. And it's also thought that they may have immunologically more susceptibility to this organism.
Okay. Next question. If pregnant parent received vaccine during the last RSV season, should the baby under 8 months receive MAB this season?
The baby should only get it if, you know, they have a high risk condition that puts them at risk for severe disease.
Okay. Is all the this is from Dr. Schulte, is all of the protection from maternal RSV vaccination due to antibody transfer, or is there also a cocoon effect in the fact that vaccinated moms are less likely to get RSV?
It's a combination, but it's mostly transfer of antibody.
Okay. Is there any guidance about giving Beyfortus in an infant has received IVIG or Hep B IG?
So far there is no guidance. But Beyfortus basically it's passive immunization, so it shouldn't interfere.
Okay. Do you recommend that physicians over 50 be vaccinated?
Yes. Given the fact that you are exposed to individuals all day long, and especially if you have an underlying condition.
Okay. The next question I see here, can you address whether immunization with NERSVAB, and excuse my pronunciation on that, is preferred more effective or equivalent to maternal vaccination based on most recent data?
So based on most recent data, obviously, if you're in RSV season, you want to protect the baby as soon as possible. So maternal vaccination does work, as you saw. But
Right.
if the baby mom didn't receive vaccine or got vaccine less than 14 days before the baby was born, then that baby should get the monoclonal antibody.
Okay. Well, that looks like it is. Oh, another question popped in. All right, here we go. I have a mother who got the vaccine in April this year, and baby was born in May. Is this child eligible now since he was not born during the last RSV season?
Baby is eligible now
Baby's eligible now. Okay.
because
These
they're
are great.
entering their first RSV season.
Okay. These are great questions. I love the engagement by our audience today. Anybody else out there? Here we go. Boom, another one. So which one should we use? Nurse Bab, or can you see the question?
You should use whichever one you can get access to. You
Okay.
saw from the information we currently have that nirsevimab does have a longer half-life, and basically we have more data on the use of that particular monoclonal.
Okay. I think that is it, unless somebody else has any other questions. You know, these webinars are so important, especially this time of year, whether it's RSV or or addressing the flu season or the COVID season that's coming up. And with that in mind, if I may, for those of you in attendance or looking at the recording, um, in a few weeks on October 23rd, we are having our Lurie Children's Community Provider Symposium, and Dr. Javari will be addressing the upcoming flu and COVID season and RSV and what to expect and what trends we're seeing in other, just like in the first couple slides. So if you're interested in that, I highly recommend you attending that one. Oh, you know what? Looks like one last question popped up here. Have serious reactions have ever been reported to those vaccines?
Well, I mean, you saw that the most common adverse reactions are injection site, swelling, pain, erythema, and you can develop a little bit of a rash. And the adverse reactions are a little bit higher with cefurolimab than with nirsevimab.
Okay, great. Well, I'd like to thank you again, Dr. Tan, for doing this today, and all of you in the audience. And if you're seeing this recording and you like it, do me a favor. Please hit like and subscribe to the Physician Services channel and rewatch this, as this information will come handy to you and your patients. And of course, the other providers in your office, I would recommend sharing this with them so they can take advantage of this session. But with that said, thank you, everybody, and have a great day. Dr. Tan, thank you.
No, thank you, everyone.